Good morning, students. I think we are really in a peculiar and strange situation where the teacher can never see the audience because of an invisible enemy which is haunting us. Anyway, whether it is an online class or offline class, you will have to bear with the situation, and you will have to read, and you will have to recapitulate and reproduce when asked in the examinations and get through the examination. Okay, I think my colleagues, they have already taken you the topics conjunctiva, cornea, sclera, and also the uvea. So the conjunctiva, the most commonly asked questions in the conjunctiva are: one is ophthalmia neonatorum, and subconjunctival hemorrhage, pterygium, and in cornea, you will have to know about hypopia and corneal ulcers, and also in interstitial keratitis and eye banking and various media for transportation of actually the eyeball once it is enucleated from the dead body. So these things also they will have to know. Vital keratoconjunctivitis is another thing, and hypopia and corneal ulcer I have already told you, and purulent corneal ulcer and bacterial corneal ulcer, and also you have fungal corneal ulcer and dendritic corneal ulcer. These are the things commonly given in the examination. And sclera, you have scleritis, episcleritis, and also the staphylomas. These things actually normally we do ask you in the examination. And in the uvea, which was taken very recently, you will have to know about actually the granulomatous uveitis and non-granulomatous uveitis and the differences between these two, and also the various causes for defective vision in case of actually uveitis, and panophthalmitis, endophthalmitis, or all these things, sympathetic ophthalmitis. They'll be asked in the examination as a short notes, a 4 marks question or a 2 marks question also. Keratic visitors can be asked as a 2 marks question. So we'll have to read all these things in the point of view of examination and also in the point of view of acquiring actually the knowledge to treat your patients in the future. Okay. Now we are going to take you on to the lens. Lens is very, very important for the undergraduates. It is, the questions are given actually in the theory and also in the clinicals. In the clinical examination, your major case will always be a lens, be it actually an immature cataract on both sides, an immature cataract on one side, and aphakia and pseudophakia on another side, aphakia and immature cataract on another side, nuclear cataracts. So anything can be given as a combination, and it can be kept in the examination as a major case for you people. And in the clinic orals also, in the afternoon, when we talk about actually asking the questions on the instruments. So we will definitely ask you most of the instruments that are kept actually, they are from the surgeries we do for cataracts or anything on the lens. Okay, so you must be very, very thorough about lens, and that gives you a great leverage over others who didn't do that. Okay, so lens is a transparent crystalline biconvex lens which is placed actually in the just behind the iris and in front of the anterior ilar face of the vitreous in a space known as actually patella fossa. So this is actually a diagram depicting actually the various structures in the eye, and this is the angle of anterior chamber where actually you can see a lot of structures. And if you see actually a little about actually the development of the eye or embryology of the eye is also important for the undergraduate point of view. The development of the eye is normally from dual ectoderm and also surface ectoderm and its derivatives and mesoderm. So the lens develops as an invagination from the surface ectoderm of the fetus, forming a lens pit, lens plate, and also a lens vehicle, later on a lens vesicle. So the lens vesicle actually separates from the surface ectoderm and forms the lens. Okay, the fibers, the lens fibers, which are actually formed, uh, they form actually the central embryonic nucleus, and they are seen actually meeting around actually the Y-shaped switches of the lens around the embryonic nucleus. So there will be further deposition of actually the lens fibers, so which correspond to the period of formation of the fetal of the nucleus. Suppose if it is a fetal nucleus just adjacent to the embryonic nucleus, the fibers are laid down between third month of gestational life to the delivery or to the birth. And infantile nucleus, the fibers are laid down actually around the fetal nucleus from the birth to the puberty. And in adult nucleus, actually, you will see, which is adjacent to, again, and periphery to the infantile nucleus, the fibers are laid down from the puberty to the end of the life. All through the life, actually, there will be deposition of the lens fibers from the epithelial cells or columnar epithelial cells, which elongate and lose their organelles, and also the nucleus at the equator of the lens. So the cortex, actually, they are the youngest fibers and they are peripherally placed. So this is the diagrammatic presentation of actually the embryology. So here actually the lens vesicle is in contact with surface ectoderm, and here actually the invagination of the lens vesicle formation occurs, and it is separated from actually the surface ectoderm, and here actually you see the lens formation there. Okay. And when you see actually the structure of a lens with the slit lamp biomicroscope, in the optical beam of the slit lamp biomicroscope, you see the various structures such as a lens capsule, and next cortex, next adult nucleus, infantile nucleus, fetal nucleus, and in the center, an embryonic nucleus. You see here, this is the lens capsule, and this is the adult nucleus, and the third one, actually the fourth one, is infantile nucleus, and fetal nucleus is there, and finally in the center you see actually the embryonic nucleus. So the formation of the various structures of the lens, you see actually in the fourth week of intrauterine life, optic pit actually develops into the optic vesicle and lens plate forms. And at 1 month of intrauterine life or gestational life, lens pit and lens vesicle they form. About 7th week of intrauterine life, there will be formation of embryonic nucleus, which forms actually the fibers around the Y-shaped sutures of the lens, both anterior and posterior. So in the 3rd month, fetal nucleus starts to develop, and it continues till the birth of the individual. That's briefly about actually the embryology or development of the lens in the intrauterine life. And now we go on to the actual anatomy and physiology of the lens. Lens, as I told you, is a transparent crystalline biconvex lens which is placed actually between the behind the lens iris and also in front of the anterior hyaloid fossa of the vitreous in a fossa known as patella fossa. Okay, and the diameter of the lens is around 8 to 9 millimeters, and the thickness actually varies varies with the age and also with the accommodation. So at birth, actually, it's around 3.5 millimeters, and as the age advances, at the extremes of the age, say around 70 years or 80 years, it will be around 5 millimeters thick. And with the accommodation also, the thickness of lens actually varies. And there are two surfaces of the lens. One is an anterior surface and posterior surface. Anterior surface has got less radius of curvature, about 10 millimeters, and then the posterior surface of the lens, which is actually 6 millimeters. The radius of curvature is 6 millimeters. And when where these two surfaces they meet, it is known as equator. And the weight of the lens actually it varies. At birth, actually, it's around 135 milligrams, and as the age advances, at the extremes of the age, it will be around 258 to 275 milligrams at the age of 80 years or 70 years. And refractive index actually is around 1.39 on an average, because the nucleus has got a higher refractive index. It's about 1.41, and the cortex actually 1.38. And total dioptric power of lens is around 15 to 60 diopters, or 18 diopters, 16 to 20 diopters. And accommodative power of the lens is 14 to 16 diopters at birth. And as the age advances, the accommodative power of the individual comes down when actually at the age of 40 years, when presbyopia sets in because of lack of accommodation power. So one will have to wear actually the glasses for near vision also. So at birth, the accommodative power is around 14 to 16 diopters. And at 25 years of age, it's around 7 to 8 diopters. And at the 50 years of age, around 40 years actually, the presbyopia sets in. And it manifests completely by 50 years also. And the dioptric power or accommodative power of the individual at the age of 50 years around 1 to 2 diopters. And the individuals at the 50 years, they will be forced to wear actually presbyopic glasses or near vision glasses of 2 diopters also. If you take actually the structure of the lens, it is again a lens capsule, anterior epithelium, lens epithelium, cuboidal epithelium will be there, and a nucleus, which is again embryonic, fetal, and also infantile and adult nucleus will be there, and cortex, the most peripheral part of actually the lens with the youngest fibers, and the suspensory ligaments of the gin actually, which keeps the lens in its place. And these ligaments, suspensory ligaments of the gene or granules of gene, they are attached to the lens surface to the ciliary body or pus. In the fetal life, again, the lens is almost spherical or round, and gradually it becomes flatter, and finally it attains actually the shape of biconvex. Lens capsule is a cuticular deposit secreted by the epithelial cells, having on the outside a thin membrane known as jonular lamellae. So lens capsule actually is thickest at the anterior pre-equatorial region and thinnest at the polar region. At the anterior pre-equatorial region, it is around 14 microns, and at the posterior polar region, it is actually 3 microns. Anterior epithelium is again a single layer of cuboidal cells, which lies deep to the anterior capsule. And in the equatorial region, the volume, the epithelial cells are columnar, and they actively divide and form lens fibers. And no posterior epithelium is there because the cells are actually used for filling up the central cavity of the lens. Lens fibers are produced by the mitosis of the epithelial cells, which elongate and undergo differentiation with pycnocytosis and eventual loss of cell organelles and also the nucleus. As the lens fibers they are produced, there will be eventually the cell organelles will be lost and the nucleus will also be lost, and they form as fibers, lens fibers. And the oldest fibers actually they will be pushed to the center, and freshly formed youngest fibers actually they will be in the periphery. Okay, as the new fibers are formed, the older ones are pushed to the center inwards, and the youngest fibers are most superficially placed. So youngest fibers actually they are known as actually the cortex, and the oldest fibers they form into a nucleus, embryonic, fetal, or infantile or adult nucleus. 90% of the lens fibers they are proteins called, and they consist of proteins called crystallines. Lens epithelium again is a single layer of cuboidal cells lining the capsule. As I said, no epithelium on the posterior surface, as these cells are used for filling the central cavity of the lens. And cells are of two types. One is in the central zone, they are actively dividing, and cells in the pre-equatorial germinative zone that give rise to the lens fibers. And these cells actually, they are interconnected with gap junctions and also desmosomal zones. Nucleus is in the center of the lens. The nucleus is a central part. The nucleus consists of a densely packed lens fibers and have higher refractive index than that of cortex. Okay, so it's about 1.41 also. And these are actually the oldest fibers, are the fibers which are actually formed in the beginning itself and which are pushed to the center. And it has got different zones which are laid down as the development goes on. The first fibers which are pushed to the center, they form actually embryonic nucleus. This is actually formed in the first 3 months of gestation. And fetal nucleus, these consists of actually the fibers which are formed from 3rd month of gestation to the birth. And infantile nucleus, these are the fibers which are formed from birth to puberty. And adult, after puberty, whatever lens fibers they are formed till the end of life, actually the lens fibers go on forming. And these are adult, they form actually as adult nucleus and also the cortex. Cortex, again peripheral part, consists of youngest fibers. Jonule of gin, this I have already mentioned, lens is held in place by suspensory ligament of gin or jonule of gin. Bundles of fibers which pass from the surface of the ciliary body to the capsule of the lens, where they join with jonular lamellae. So lens transparency is at most important because this helps in focusing the image onto the retina. Okay, so there are 5 factors which are responsible or which actually maintain the lens transparency. One is avascularity of the lens, and secondly, a tightly packed lens fibers, and third one is arrangement of lens fibers in parallel manner. And fourthly, semi-permeability of the lens capsule is also very, very important. And finally, the pump mechanism of lens fibers that regulates electrolytes and also the water to maintain a relative dehydration of the lens. Autooxidation and higher concentration of glutathione maintains lens proteins in a reduced state and maintains actually the integrity of the lens. The epithelium contains sodium, potassium ATPase and calcium activated ATPase, but the active transport of electrolytes and amino acids across the lens capsule into the aqueous humor. Functions of the lens, it secretes actually the lens capsule and also lens fibers. It regulates the transport of actually the electrolytes and also metabolites, nutrients to the lens fibers. This is again a figure depicting actually the various ingredients of aqueous humor and also the lens, and how actually the various ingredients they are transferred from aqueous humor to the lens by way of active transportation and also by way of diffusion. So the water, as you see, actually it's about 99% in aqueous humor, but in lens actually, since you should have a relative dehydration of the lens for its transparency, it's only a 66%. And here actually this transfer of water is actually by diffusion or leak. And sodium in the aqueous humor is around 144, and in the lens actually it is 20. So if it is more of sodium, actually it will be an active transport pump mechanism which pushes actually the sodium to the aqueous humor. And potassium is around 4.5 and 125. And glucose is in aqueous humor it is more when compared to actually the lens. Lactic acid is also in aqueous humor it is less when compared to the lens. And glutathione And inositol, glutathione actually it is synthesized actually in the lens. Inositol is another thing which is 5.9 in lens and 1.1 in aqueous humor. Amino acids, they are in plenty in about 25 in lens and 5 in aqueous humor. And 33% of the proteins, they are synthesized and 0.04% in aqueous humor. So this is how actually there will be transfer of the electrolytes and amino acids from the lens to the aqueous humor. And the glucose will be taken actually from the aqueous humor for its metabolism by the lens. Metabolism of the lens requires actually continuous supply of ATP for active transportation of ions and also amino acids, and for to maintain actually the relative dehydration of the lens, and also for continuous protein synthesis and also GSK synthesis. The lens is dependent on glucose metabolism for glucose on aqueous humor because it is avascular, and some amount actually the nutrition is given by actually the vitreous also. So the metabolism in the lens, glucose in lens actually it is metabolized by nearly about 4 pathways. But one is about 80% of the glucose is metabolized by glycolytic pathway, and 15% by HMP shunt, and the rest is by Krebs citric acid cycle. And sorbitol pathway, though it is a small proportion which it takes actually as a share for metabolism of the lens, it's very, very important in actually in diabetic cataracts, where actually sorbitol, it causes actual overhydration of the lens matter. So cataract, it is defined as any opacity in the lens or its capsule, whether developmental or acquired. Okay. So cataract, normally cataractogenesis or the uh, way actually the cataract forms. A cataract is caused by one is degeneration, opacification of already formed lens, and the formation of aberrant lens fibers, which occurs actually in posterior subcapsular opacities, and deposition of other materials in their place, such as actually the copper, iron, and all these things. Okay. Aberrant lens fibers are produced when the normal lens fibers actually they cannot be produced, and it results in most of the cases in posterior subcapsular opacity. Abnormalities of the lens proteins and disorganization of the lens fibers are the cause for loss of lens transparency. Antioxidant mechanism of the lens is important because the oxidative damage caused by superoxide, hydrogen peroxide, lipid peroxide, and lipid hydroperoxides. So they cause actually the opacification of the lens. So the crystalline lens has got protective mechanisms against these oxidative damage. And there are certain preventive antioxidant mechanisms of the lens, which causes actually, which prevents actually the damage by the so-called superoxide, hydrogen peroxide, lipid peroxide, and lipid hydroperoxides. So one is an enzymatic defense mechanism, and another one is a non-enzymatic defense mechanism. So enzymatic defense mechanism, it includes glutathione peroxidase, and catalase. A non-enzymatic defense mechanism is again vitamin C, vitamin E, and also carotenoids, and probably carotenoids. So the reasons for cataract formation are not clearly depicted, but variable causes are there in different cases. Any physical or chemical factor which disturbs the critical intra and extracellular equilibrium of the water and electrolytes or deranges the colloid system of the lens fibers, it causes opacification. Lens has a complex antioxidant system which protects actually against from the aforementioned actually harmful oxygen radicals. In complicated cataract, there will be fibrous metaplasia of the fibers, which results in actually cataract formation. In case of actually acute angle closure glaucoma, there is opacification of the lens epithelium, focal opacification of the lens epithelium, which is otherwise known as actually glaucoma flecken, and the epithelial cell necrosis occurs in these areas. And in case of actually storage disease such as Fabry's disease, metabolic diseases such as Wilson's hepatolenticular degeneration, and toxic reactions such as siderosis in case of iron and sarcosis in case of copper toxicity, and abnormal products of metabolism, drugs or metal deposition can cause also a complicated cataract. Biochemically, three factors are responsible in the opacification, the formation of cataract or in the opacification of lens. First and foremost is, and maximally, it is hydration. And secondly, denaturation of the lens proteins. And third one is sclerosis, a relative slow sclerosis of the nucleus. Hydration is a prominent feature, as I have already mentioned, in early and rapidly developing cataract. Droplets of fluid and vacuoles actually they accumulate under the capsule and in between the fibers. So tissue swells and it becomes opaque, and it's otherwise known as a waterlogged lens and also intumescent cataract. Here, the opacification is reversible. Usually, it may occur actually in juvenile insulin-dependent diabetic patients. Suppose if the diabetes is well controlled, actually in such cases, actually the opacification is reversible. Maybe the opacification and also the droplets of fluid accumulation in case of juvenile insulin diabetic patients, it may be because of osmotic changes in the lens and semi-permeability of the capsule. In traumatic cataract, the capsule is ruptured and the lens fibers they swell into the AC and bulge into the AC, and the aqueous actually penetrates into the, it seeps into the lens, and it causes actually the opacification. Proteins are denatured with an increase in insoluble proteins. So that causes a dense opacity in the lens. And this dense opacity, normally it is irreversible and it is permanent. And it occurs typically in young lens or cortex of the adult lens where metabolism is relatively active. Rare in the nucleus. So slow sclerosis, the sclerotic changes are seen in older and inactive fibers of the nucleus. So when hydration process in the lens is predominant, it is known as actually soft cataract. When sclerosis is predominant, it is mostly known as actually hard cataract. So we definitely ask you in the examination the differences between the slow cataract and hard cataract, and we'll have to mention. We'll come to that later. So there are certain risk factors which cause actually the cataract. The first and foremost is ACE, and second is the sunlight, UVA and UVB light. And thirdly, severe dehydration, which occurs in the children or adults after gastrointestinal upset. And diabetes is another systemic disorder which causes actually cataract, which enhances the onset of cataract in a senile cataract, and also it causes cataract by itself, diabetes. So deficiency of vitamin A, C, E, and smoking, the cyanide which is present in smoking actually, it causes the cataract formation. Corticosteroids, so they are known to cause actually cataract. And genetically, there are certain cataracts which are actually inherited. As age progresses, there are certain changes which occur in the lens. One is the semi-permeability of the capsule is impaired. So that causes actually the problem and influx of water logging, and also the cataract formation. Increase in inactive insoluble proteins will be there, and antioxidative mechanisms which are normally present in the lens, they become less effective. And sulfhydryl containing glutathione and ascorbic acid are decreased in advanced age group and also in the cataract. Again, there are other factors actually which can cause cataract. One is deficiency of amino acids, that is tryptophan, or B2 riboflavin, and administration of toxic substances such as naphthalene, lactose, and also galactose and thallium. And dinitrophenol, which is actually used for slimming. Insecticides and radiation can also produce posterior cortical cataract, and toxic products in cyclitis, and also iridocyclitis. It can actually produce a complicated cataract. Cyanide from cigarette smoke can produce cataract again. Hypocalcemia or parathyroid tetany can also cause cataract. Anticholinergics group of miotics such as pilocarpine and all these things. And systemic steroids or local steroids, when used for a prolonged period, can also cause cataract. Systemic diseases which cause cataract are adult diabetes mellitus or juvenile diabetes mellitus. It causes a posterior subcapsular cataract or a cortical cataract or a nuclear cataract. Juvenile diabetics, normally a snowflake type of or snowstorm type of cataract will occur. Parathyroidism, which occurs by parathyroid disease, or inadvertent removal of actually parathyroids in case of thyroidectomy. It may result actually in a cataract, where you see actually the flakes of lens fibers, opacities in the cortex and subcapsular region, and total cataract can also form. In galactosemia, Alport syndrome, Down syndrome, all these things actually they are associated with cataract formation. So the physical factors which actually can cause cataract are, one is trauma. So in trauma, be it actually blunt injury or be it actually perforating injury, sclerocorneal perforations, so they cause actually cataract, a flower-shaped rosette, anterior flower-shaped rosette or posterior rosette cataract can occur. Electric cataract, electric shock, anterior subcapsular cataract, it can occur whenever there is an electric shock actually which goes into the body. And radiation cataract, the people who are exposed to the radiation, be it a gamma radiation or a beta radiation for treatment for any malignancy in the vicinity of the lens or eye, so it can also result in actual radiation cataract. Dermatological, atopic dermatitis and ichthyosis. So these are actually the dermatological conditions which are associated actually with the cataract formation. And there are certain toxic agents which can also result in cataract formation. One is a corticosteroid, anticholinesterase, and chlorpromazine, chloroquine, busulfan, copper, iron, gold, and cigarette smoke. All these these are the toxic agents which can give rise to actually the cataract formation in the long run. Local ocular diseases which cause actually cataract or glaucoma, be it actually an angle closure glaucoma or an open angle glaucoma, so it can give rise to actually cataract, uveitis, iridocyclitis, or a pars planitis. All these things they may give rise to actually a complicated cataract. Retinitis pigmentosa, so where actually this is a inherited hereditary condition where there will be night blindness, and these people in the long run, they actually the cataract formation in these individuals is earlier than actually the normal individuals. Retinal detachment and surgery, so be it a scleral buckling or be it actually the intraocular gases injection or silicone oil treatment. So this may be actually followed by actually the cataract formation. And tumors of the eye, be it a malignant melanoma or retinoblastoma, so it can also give rise to actually the cataract formation. So classification of cataract again, it can be a congenital and developmental cataract or an acquired cataract. So acquired cataract, there is the classification is again etiological classification, and also we have actually morphological classification. Etiological classification, so the cataract can be a senile cataract, it can be a traumatic cataract, or it can be a complicated cataract, metabolic cataract, radiation cataract, toxic, cataract associated with skin disorders, and miscellaneous. morphologically, it can be a capsular cataract, anterior capsular cataract and posterior capsular cataract, or it can be a subcapsular cataract. Just behind the capsule, there can be actually cataract formation and opacification of the lens fibers. The anterior subcapsular cataract or posterior subcapsular cataract. And the cataract can be a cortical cataract and supranuclear cataract, where exactly the fibers adjacent to the upper pole of nucleus, actually they can opacify and give rise to supranuclear nuclear cataract. And nuclear cataract, various zones can be involved. Embryonic cataract in case of actually a congenital cataract, where the patient actually is born with actually opacity, and where it depends actually which part of the nucleus is affected. It depends on when exactly the intervention or disturbance of the formation of the lens fibers will occur. During that period, only that particular part of that particular zone of the nucleus will be affected. Suppose if it is before 3 months of intrauterine life, it is embryonic nucleus which is will be affected, and if it is actually from third month to the birth, it will be infantile nucleus, and sorry, it is fetal nucleus, and from birth to puberty, it is infantile nucleus, and after that till the end of life, actually it is mostly an adult nucleus. And polar cataract, it can be an anterior polar cataract or a posterior polar cataract. So the anterior polar cataract and posterior polar cataract, they are associated with certain ocular anomalies. So you see actually here the various cataracts. So the symptoms of cataract. So usually the patients, they come for a blurring of the vision, a gradual progressive loss of vision. So in this actually, whenever a patient presents with gradual progressive loss of vision, we'll have to keep in mind certain conditions which cause this gradual progressive loss of vision. First and foremost is the cataract, and second one is you have the refractive errors, and the third one is a corneal opacities, corneal degenerations, and a primary open angle glaucoma is a silent killer of vision, and age-related macular degenerations, okay, retinal dystrophies. All these things actually they cause uh, the gradual progressive loss of vision, painless gradual progressive loss of vision. Here, the blurring of the vision is usually painless. As you see, actually, the patient with cataract, he sees the picture like that. Okay, and these people, they will be frequently changing the glasses. It's because actually the refractive index of the various parts of the lens differs, and so as the mature cataract, the cataract formation progresses, so these people, they will have to change their glasses frequently so as to have a clear distant and as well as near image. So polyopia is another, or diplopia. This is another complaint, actually, the patient complains. Multiple images due to irregular refraction by different parts of the lens surface. So usually whenever they look at actually a distant object, they may have actually diplopia, or the same object may appear as multiple objects. So this occurs because of the irregular refraction by the different parts of the lens. And the patient also may see multiple moons at the night, and, and colored halos is another thing which these people, they may complain of. So there are three causes for colored halos, and we'll have to differentiate actually colored halos from one case to the other. The three cases are three conditions where actually the colored halos are seen are. One, first and foremost, is purulent conjunctivitis. Second one is an acute congestive stage of angle fluorescent glaucoma, and the third one is an intumescent cataract. Okay, so in case of actually purulent conjunctivitis, if you wash saline, irrigate actually the conjunctival sac with saline, the mucopus actually gets washed up, and the patient will not have any colored halos. And in case of actually acute congestive glaucoma and also the intumescent cataract, the colored halos caused by these two things, you will have to do a test known as Finsham test. So the Finsham test actually, what we do is we pass actually a stenopic slit in front of the eye of the patient, asking him to look at actually a bulb where he is able to see actually the colored halos, just like a rainbow. And in case of actually intumescent cataract, so the colored halos will be broken. But in case of acute congestive glaucoma, the colored halos they remain intact. This is known as Finsham test. Okay, and the deterioration of the vision depends in case of cataract on the density and the position of the opacity. Suppose if it is very thick opacity, so normally these people they will have the difficulty to do their daily routine. And if the opacities are placed actually in the center, it's an axial opacity. So then the visual deprivation will be faster. In case of actually the peripherally placed lens by the lenticular opacities, so the patient will not have any problem during the daytime because the pupillary constriction will be there because of the bright light and everything, and the opacities are closed or camouflaged or they are actually closed by the iris. So the central axial portion of the lens is clear, and the patient will be able to see better. And improvement of near vision, it occurs in case of actually the nuclear cataracts. Murthy, సంతోష్ ఇది పంపించాడు రామూర్తి చెప్పాను కదా ఫండస్ కెమెరా కాదు ఆటో రిఫ్రాక్టోమీటర్ పంపించాడు అదొకటే పంపించాడు ఫండస్ కెమెరా కాదు ఆటో రిఫ్రాక్టోమీటర్ పంపించాడు అదే దట్ వి ఆర్ యూజింగ్ ఇట్ ఆల్రెడీ అది హ్యాండ్ హెల్డ్ ఆటో రిఫ్రాక్టోమీటర్ పెరిఫెరీకి తీసుకెళ్ళి హ్యాండ్ హెల్డ్ ఆటో రిఫ్రాక్టోమీటర్ అది పెరిఫెరీకి తీసుకెళ్ళాలి క్యాంప్స్ తీసుకెళ్ళాలి చూస్తున్నా వాడుతున్నా అదొకటే పంపించాడు sorry I was interrupted by the dean. Okay, in case of actually nuclear cataract, there will be a myopic shift. Usually these cataracts they do occur in the latter half of life, usually. So for the presbyopia sets in when you attain around 40 or 50 years of age. And if it is associated with actually nuclear cataract, so the presbyopia will be delayed because there will be a myopic shift in case of nuclear cataracts and hypermetropic shift in case of cortical cataracts. Okay. So when there is a myopic shift actually in nuclear cataracts, the people they will be able to read actually the near print very easily, and the distance will be masked by these people. Okay, so that's what we call actually second sight. So when these people they are able to see actually read without glasses, and the distance is a little difficult for them, and that's what we call actually second vision, second sight in case of nuclear cataract. So whenever you see a patient with a gradual progressive loss of vision, you will have to differentiate or rule out certain disorders such as a primary open angle glaucoma and a macular degeneration and also optic atrophy. So age-related cataract or senile cataract is very rare before 50 years, and it is associated, may be associated with the diabetes mellitus or other metabolic disorders. And usually after 70 years, I can say about 80 to 90% of the people actually they can have cataract, not all. And male is to female incidence is almost equal actually in our studies. We haven't seen actually any much difference. And usually it is bilateral. And the genetic influence is definitely there. And tropical countries, they do have actually the occurrence of the cataract formation is 10 years earlier when compared to the other countries. Two types of senile cataracts are there. One is a cortical cataract, which results by hydration followed by coagulation of the proteins. And the second one is a nuclear cataract. It's because of the sclerotic cataract and this is slow sclerosis of the nuclear fibers. It results in nuclear cataract. So there are various stages of maturation of cortical cataract. And the first and foremost is stage of lamellar separation. And second is incipient cataract, and third one is intumescent cataract, and fourth one is immature cataract, and fifth is mature cataract, and hypermature cataract, and morphagnia hypermature cataract. So in case of lamellar separation, which is the earliest change in cataract formation, there will be demarcation of the lens fibers or cortical fibers. The lamellar separation is by fluid, and it can be seen by a slit lamp biomicroscope only. You cannot see it with an ordinary look and touch. And the pupil will look, the color of the pupil will be gray color. Gray color will be there. Okay. Incipient cataract, the second stage. Uh, these are actually the opacities with clear areas in between the opacities. So two types are noted. One is cuneiform and another is cupidiform. So in cuneiform cataract, wedge-shaped spokes of opacity will be there, and it will be mostly they are seen actually in the periphery. They lie in the cortex both in front and behind the nucleus. And opacity starts as clefts and vacuoles between the lens fibers due to hydration of the cortex. And there will be variation in refractive indices in the various sectors of the lens. And this results in actually in irregularities of the refraction, and the patient will have actually polyopia, seeing multiple objects. And usually the cuneiform cataract most commonly seen in the lower nasal quadrant, and it can be seen only with a dilated pupil. And the patients in this stage actually they complain of glare due to oncoming headlights or bright light, whatever it is. So cupidiform cataract actually is a saucer-shaped opacity which is placed in the center, just inside the capsule. Gradually, it extends outwards. Vision, in this case, actually of cupidiform cataract, is considerably decreases even in the beginning because the opacity is at the nodal point. Intumescent cataract, as the cataract matures, so the deeper layers actually uniformly they become white and opaque. So progressive hydration of the cortical layers and the swelling of the lens, waterlogged lens is cause for this intumescent cataract, and AC becomes very shallow in these cases, and sometimes actually they may result in a phacomorphic glaucoma. Here, this is the picture of an immature senile cortical cataract. So the immature senile cortical cataract actually, the color of the lens is grayish white, and the vision will be around 6-9 to say hand movements or contact finger close to face, and iris shadow will be present. And when you do a distant direct ophthalmoscopy, as you see actually the opacities against the red fundal cone. Okay. So when you throw actually an oblique beam of torchlight onto the pupil, so the crescentic shadow of the pupillary margin will be seen on the anterior capsular grayish opacity of the lens. For you to actually observe the iris shadow, you must have both a lenticular opacity and also clear, transparent, clear lens fibers. Okay. So this is a figure depicting actually how you test for an iris shadow. So the beam is thrown into the pupillary region, and the iris shadow will be seen like this. Okay, in this pupillary region behind actually you have lens, and the iris shadow will be seen. And this is a mature senile cataract. Opacification is complete. Whole of the cortex is involved, and the color is fairly white. Okay. So the to differentiate actually in immature senile cortical cataract from mature senile cortical cataract to hypermature cataract, how we do it is actually the color of the lens. In case of immature senile cortical cataract, it's grayish white. In case of mature senile cortical cataract, it's fairly white. In case of actually the hypermature cataract, it is milky white. Okay. So in case of immature senile cataract, the vision will be 6:9 to say around say CFCF or hand movements. In case of mature and hypermature cataract, it will be a perception of light only, unless the patient has got a problem in the posterior segment. Okay. So when you do a distant direct with the iris shadow will be present in case of immature senile cortical cataract because there is an opacity and also some transparent lens fibers. So in case of mature and hypermature cataracts, the iris shadow will not be seen because there are no transparent fibers at all. The whole lens is actually opacified. Okay. And when you do a distant direct ophthalmoscopy, in case of actually mature senile cortical cataract, what you say is actually the opacity is against a red fundal blue. In case of actually mature and hypermature senile cortical cataracts, because the lenticular opacity is complete and it's occupying the pupillary region, you will not see actually any red fundal glow. Hypermaturity can be two types. One is sclerotic type. Here actually the lens progresses, the opacity progresses uninterruptedly and the cortex becomes disintegrated into a pultaceous mass. Anterior capsule is thickened and wrinkled. Capsular calcification will also be there. Lens becomes shrunken, giving rise to sometimes an iridodonosis, that is tremulousness of the iris, and subluxation of the lens due to degeneration of the jonules of chin can also occur in certain cases. In Mogdagnian cataract, the cortex becomes fluid, milky, and nucleus shrinks and sinks to the bottom of the lens. The nucleus looks like a brown mass limited above by a semicircular line, and it alters its position by changing actually by moving the head this way and that way. Okay, and this is Morgagnian cataract, and this is actually the nucleus, and this is all actually milky cortical fluid. Actually, the cortex is liquefied and goes into actually it's completely fills the bag with fluid. Okay. Rate of development of cataract actually depends. It varies from individual to individual. It may take actually many years, and it may never reach maturity in certain cases. And rapid maturation can occur in certain individuals. And periodical examination of these cases is important because you should know when to act upon, when to relieve actually the patient of his suffering. Okay. I think we stop here. So to recapitulate what is said, we have talked about actually the embryology of the lens. It starts actually the lens formation in the fourth peak of intraretinal life, where actually when actually the embryonic nucleus develops, and infantile nucleus seventh week, and later on actually it progresses, and we have seen actually the anatomy and physiology of the lens, and we have also seen the classification of cataract and the definition of cataract, classification of cataract, and all these things. Any doubts? అయిపోయింది. మీకేం డౌట్స్ ఉన్నట్లేదు. రాలేదు. అంతా అర్థమైపోయింది. అసలు ఏమీ అర్థం కాలేదో తెలియదు. తీసిడా లేదా
అంటే ఆపడానికి సార్ ఏం లేదు సార్ చివరి వస్తారు అండ్ ఇంకోటి డౌన్లోడ్